Hello, everybody, and welcome to episode 2 of Blood Matters, a podcast for nurses. I am one of your co-hosts, Emma Chalmers, and I am once again joined by the wonderful Michelle Kenyon, who I am happy to do episode 2 with. Today's guests, we're really excited to let you know, are Angela Leather and John Murray, and today's topic of conversation is actually, let's talk about sex. We want to talk to you about sex and intimacy for patients in and around their transplants, why it's difficult and how we can help as nurses. So thank you very much for everybody for joining us today. It's wonderful to have you on the podcast.
Thank you.
No worries. So today is really a little bit different. We had hoped to have this out a little bit earlier in the year, but we think that it's important that you talk about sex at any point during a patient's cancer journey, and particularly around stem cell transplants. So what I'd love is if we could maybe start with you, John, and first of all, if you could give us a little bit of an introduction and tell us a bit about what you do at the moment in your current role.
Oh, hello. Well, thank you for inviting me, Emma and Michelle. I'm a nurse clinician, which is a slightly unusual title, I suppose, to some people who might be listening to this. So I'm an advanced nurse who's done a master's degree in the past to enable me to have some additional clinical skills. And I look after people post their allogeneic stem cell transplant in an outpatient setting. So I see people in our long-term late effects clinic. I see them in our acute setting in their immediate post-transplant clinic. I also see them as walk-in patients. We don't have an accident and emergency here at the Christie Hospital in Manchester, but we have a haematology day unit where our patients post their treatment can act as walk-ins if they're unwell. So I assess patients in that setting, and I also do our bone marrow clinic, and a few other bits and pieces. We did a bone marrow harvest this morning, for instance. So I'm pretty much across all of the post-allogeneic stem cell transplant patients.
So a very complicated group, particularly post-allogeneic transplant.
People have a lot of things going on in the post-transplant setting. A lot of people coming through transplants often having their minds, oh, right, I've had my transplant and I've got out now, it's all over, I'm just going to recover nice and quickly, and there we go, it's all done and dusted, and I'll be back to work in a couple of weeks' time, even though they've been told in great detail before their transplant that there's a lot of post-care that happens and they'll be backwards and forwards to hospital. A lot of the time people push that to the back of their mind and they think, oh, I'm going to get through this nice and easy, my life will be straight back on track, I'll be working full-time in a couple of weeks, picking the kids up from school and running around like I was doing before. And all of a sudden I think reality kind of kicks in. And they realize that they're not going to be jumping straight back into what they were doing. So I think as nurses, we try and reinforce all of that information that they've been given pre-transplant in the post-transplant setting at the same time as we're doing all of the care that these guys receive after they've received such a complicated and intensive treatment.
It's definitely a marathon, not a sprint. And I think we all have to remind our patients of that. So we're obviously here to talk about something very, very specific and something that I think that sometimes can be shied away from. So why do you think, John, that we should be talking to our patients about their sex lives?
Well, it's one of those conversations that is incredibly delicate. And I think that a lot of people shy away from this all around the treatment. It doesn't really matter if you're a transplant patient or not. This can be people coming through for ordinary induction chemotherapy that will never turn into a transplant for that person. It could be people with a different diagnosis that transplant isn't even an indication for them. And I think that sex and sexuality and people's sex lives and everything that rotates around that is something that is very personal to that person and their partner. And if they haven't got a partner to that person on their own, there's a lot of things around it. So it's conversations that we should have with all of our patients at multiple times throughout their treatment pathway. And I think as professionals, sometimes we shy away from those conversations because we find them difficult. And it might be because it opens up a can of worms that as the person asking the question, you might not have the answer, that the question comes back to you. Well, okay, you've asked me something and I give you an answer. Now, what do I do with that answer? And I think that's where the difficulties come for a lot of us, and that's nurses, doctors, physios, OTs, everybody who has a connection with that patient has an opportunity to talk about sex, sexuality, and people's sex lives, and how that is affecting them and their treatment and moving forwards. So I think that once you wrap your head around how important it is for yourself, because if you think, well, okay, if I'm starting off from my point of view, it's important to me, so it's probably important to other people. And then you ask those questions, which are going to be difficult, and you might not have the answers. But it's knowing that you don't have the answers. How do you then signpost somebody? How do you point them in the right direction and have friends, colleagues, and other professionals that you can point them at and say, I can't help you today, but I know a person who can. And this is the person, this is where they are, and this is what we're going to do about it. And I'm going to help you to access what you need to help you and your partner, or you on your own, move forward with this. And I think that's the crux of it really, is being open and honest with your patients and saying, look, I'm going to ask you some difficult questions. If you don't want to answer them, that's fine, that's your choice. But I'm going to ask you them, and whatever answer you give me, we'll take it from there. And I kind of always lay that groundwork with people, saying there's a couple of unusual questions that I'm going to ask you, and you know, we get into it, and sometimes you're very surprised at what people come back with, and most of the time it's, wow, what a relief, I'm really glad somebody's asked me. I've been bottling this up for weeks or months, or in some cases years, that people have been worried about asking questions. And as soon as you ask them that, it opens a floodgate, and they're able to then express their concerns about what has been worrying them over those days, weeks, and months.
Absolutely. Yeah, I think these are really important conversations that we should all be having. What kinds of concerns are your patients actually bringing to you when that conversation has begun and they're feeling comfortable talking to you? What are the things that they're bringing up?
So I think, well, as there are two of us here, there's myself and Angie. And Angie has obviously more of a, well, not obviously. So I would say Angie has more of a steer today from our conversations on the female side of this. So what I'll do is I'll take the male side of this, and we can probably tease it out in that way. So when I'm talking to my male patients in clinic, as soon as I've got somebody in clinic and we're getting through those first few months of concern post their transplant, so you're worried about their counts, you're worried about infection, you're worried about how the transplant it's actually gone. Is it working? Are we now in a safer and a happier place where the concerns about the specific bits around the transplant become less of a worry for people, and they can then start to think about what's going to happen in the rest of their life. They're in remission, they haven't got any other things going on, and you're starting to get back a degree of normality. They might be thinking of going back to work. They might be, getting out and about and doing more things. So I think from my perspective, what I tend to do is then broach things at that point and ask them, how are things at home? Knowing, I would hope that I've now known them for a while, I know if they've got a partner or not. Often they come with, and sometimes they don't, depending on how well they are or not. Now, if they're both in the room, that can be a more delicate conversation to have, because you're asking a question of two people, not just of one. And I think that can sometimes be a little bit more delicate, because sometimes the male maybe, you can see people, they're looking across at their wife and thinking, do I answer this question or not? And I'll ask them, are you having sex? Is this okay for us to talk about this today? And if they say no, I'm just shut you down, that's fine. So we can come back to this at another point if you want to, but if you don't want to talk about this anymore, we'll just leave that as it is. And it's really just having that opening question about, how are you doing? What is going on? Tell me a little bit about your life and what is happening, and what concerns have you got? The ones that tend to come back from most of my male patients is that I've lost some interest in sex. I'm having some difficulties either obtaining or maintaining an erection. And what do I do about that? I'm getting frustrated, my partner's getting frustrated, and we've stopped trying now. And that is a very sad situation where people have tried and they get to a point and they go, forget it. And they've been in a relationship sometimes for years and years and years. And that is a travesty. And on our part, we can't just leave people in that situation. It's like, great, we've helped you out with your cancer. We've helped you out with your infections, your graft versus host disease. off you go then. See you later. We're not going to worry about all the other psychological problems that you might be having and your difficulties with sex and sexuality. See you later. I think we do have a responsibility. We're looking after this patient as a whole. So I might not be able to give them testosterone replacement or sildenafil or the other things, but I do know an endocrinologist. I do know other people who can help with sex and sexuality that I can refer them to. But if I don't ask that question, I can't send them to see those people. So I think those are the things that tend to come back quite quickly, is if people are trying to engage and they're unable to.
And Angie, is there anything in particular that the female patients generally are coming to you with?
So most of the time that the patients that will come to me will be mainly because they're unable to have sex, or it's so uncomfortable that again they stop trying, and they feel that then it's like, what am I going to do? And they feel that they are the only one, that they've got no one to go to, don't know what to do to try and overcome this. And it usually comes up in conversation in one of the clinics, if nothing else, to sort of like say, this is what's happening. This is what's happening, and how do I get around it, really? So most of the time it's either pain on intercourse, it's impossible intercourse, and sometimes the patients will also just come through general activities of living. So they may have pain when they're wee, because if they've got excoriation because of graft versus host disease, then the vulval area can be blistered, and that can be extremely uncomfortable for them. So it might not be the act of sex itself, but it may well be then that you identify that there's other issues going on.
Thanks, Angie, and we will get you to introduce yourself in a little bit. Once I've finished picking John's brain, Michelle's going to have a chat to you as well. So my final question at the moment for you, John, and we will bring you back for some more sort of general questions a little bit later, is people know your name. We know who you are. We've seen your name in articles. What's some of the research that you've done recently, or what's some of the research you've been involved in recently in terms of sex and intimacy in our patient group?
So there's been a couple of EBMT studies that have been performed in the last couple of years. So there was a study called SFAST, which was sexual function of adult long-term survivors and their partners after allogeneic stem cell transplant. And this was a very interesting study that was pulled together by Eeltink, who's from the Netherlands. And this was looking at sex and sexuality of patients and their partners, which was very different to a lot of other studies that had been performed. So it was very interesting to interview both people, and we did this through a questionnaire. And unfortunately, there was some difficulties with recruitment to this. So it goes back to our earlier statement, really, of clinicians, nurses, doctors, whichever health professional, talking to our patients. So asking patients to go into a study, asking about sex, from our perspective, as the clinician asking, it was causing, I think, some anxieties. And as a consequence, not as many patients were approached as potentially could have been. So I don't think that in the end we recruited as many people as we would have liked. We still had some decent results showing that in the main it was. I have some figures here if we want to be a little dry with some figures, but we found that 47% of male and 65% of female allo patients reported clinically relevant sexual problems. And then 29% of males and 51% of females, and that's a massive number, reported being currently sexually inactive after their transplant, which goes back to that earlier point of, if we don't ask, we don't know, and we can't help. So I think that's one of the most important things to come out of the SFAST study, is we really need to talk to our patients. And one of the things that came out of that also was the fact that patients weren't spoken to or asked or informed about sex pre their transplant. So again, at the point of diagnosis, going through your induction chemotherapy, everything is about getting you into a state of remission that can allow the transplant to happen. So the other things get pushed to the side, not because they're not important, but other things become more important in a way. So patients felt that after the transplant, the things that potentially could have been spoken about hadn't been, and then they weren't spoken about afterwards. So they're in this position where they had no pre-existing knowledge. They weren't being asked in the post setting, so they were in a complete limbo land where they really weren't sure who to ask, when to ask, what to ask, and what to do with anything really. And then as soon as you ask them, they get this light bulb moment of, crikey, somebody's interested in this and interested in me, and I'll talk about it. So that was a really interesting, I think, and an informative point for us as a group. The other study that was performed was a massive study that was performed as a combination of, oh crikey, it was cross Atlantic really, so multiple organisations, EBMT being one of them, and that looked specifically at male specific late effects in transplant. So it was the Complications Working Party as well as the nurses group and EBMT in the whole. So that gave us a bit of a look at graft versus host disease, hypogonadism, secondary cancers, and sexuality. And it was looking at what research is out there, how relevant that research is to our patient group, and what can we do with that? How can that inform practice? And it's showing that there isn't an awful lot of research out there into male-specific effects, which was interesting in itself, because you would have automatically thought that, males would be, in every other societal piece of life, it's, sadly, I am a white, middle-aged, slightly balding man. So I fit the stereotype of every kind of thing you can think of. So therefore, not therefore, but most of my colleagues are similar to me, are white, middle-aged men. So you would think that we'd automatically start researching things that are important to us. But that doesn't seem to be the case, which in itself is an interesting fact to find. So there is more work that needs to be done on this. We need to look in more detail at some of the male-specific effects. Graft versus host disease, for instance, depending on which papers you read, the incidence is somewhere between 5 and 20% in a post-transplant setting for chronic GVHD. That's mainly because we don't ask. And because we don't ask, it's really difficult to report. And there's no specific studies that are developed to look specifically at that. It comes as other parts of chronic GVHD studies, where it might be a little sideline that somebody says, oh crikey, has anybody asked about genital GVHD? And there might be a little tick box at the bottom somewhere. So again, it's coming about information and asking the right questions at the right time that enables us to have answers to help future patients. And I think that is really important.
I'd agree. I think they sound like fantastic studies, and we'll try and get them linked up for people to have a look at on at least the EBMT site for the podcast. So John, thank you very much. We'll come back to you shortly, and I'm going to hand over to Michelle now to have a chat with Angie, and then we'll come back together at the end and just do a couple of sort of quick fire questions to close off the podcast. So Michelle, over to you.
Thanks so much, Emma. I'm very conscious I've been extremely quiet so far, listening intently to John's responses to your questions and learning, as I hope everyone who's tuned in is as they go along. Angie, it's so lovely to have you on the podcast, and John, huge thanks for joining us for this second episode, and looking forward to our joint chat, chinwag, later on. So Angie, I had a couple of questions that kind of came to mind while John was talking, actually. And I work with transplant recipients at all stages along the transplant pathway. And there was a sort of really interesting article that I read by Karen Australia a number of years ago. And she had done a piece of research that kind of indicated that those people that resumed sexual activity within the first year after their transplant tended to have fewer problems in the longer term. And so I guess, for me, there's something there that I wanted to ask around, if we're only starting to ask these patients about sexual function and whether they're having sex when they reach our late effects clinics, there's a lot of time in between then that we have missed opportunities potentially. And I guess there's something around empowering nurses who are working with patients at all stages of their transplant experience, and not just, I guess, in our clinics, but also on our wards. And I wonder if you have any tips really for the frontline nurses and what we can do for those nurses in terms of education, in terms of tips to empower them to help to start these conversations.
Oh, thanks, Michelle. And yeah, thank you for inviting us again. And I echo John's words. It's great to be here. And I agree with you. It's really important to discuss it early on in the transplant process and even before transplant, because if you're waiting until the signs and effects of the treatment, then often it means that the treatments that's needed to try and resolve it is much more intense. It's obviously much more psychologically distressing to the patient. So as a nurse, I felt that this was really important, and the reason that I've become interested in this in the last sort of like 15-16 years is that we saw patients that were coming through post-transplant, and we found that they were unable to just go and have a normal smear test at the GP because they were either too dry, they couldn't get the speculum in, and it was really difficult. So it was then I started to ask our patients more about what's going on. Have you got any specific problems? And found that there was an awful lot of ladies out there that were suffering in silence. And I think from an education point of view and asking that question, as a nurse, you need to have a little bit of confidence in knowing your patient. And often when they're on the ward, you do get to know your patient really well. So it's a great opportunity. But sometimes as nurses as well, and as doctors, we're much more interested in what the blood counts are doing, what the lines are doing, whether they need antibiotics or chemotherapy, as opposed to asking the much more personal, intimate questions about their sex life and about their social circumstances. So I think to have some idea, again, John mentioned it in his conversation a minute ago, was to actually have somewhere to signpost them to. If you don't know the answer, which is absolutely fine, nobody knows all the answers, it's go and find somebody that can help them. But it's actually just opening that opportunity for the patient to come to you and say, actually, yeah, I've got this problem. I set up a women's health clinic several years ago, and I try and see the patients at 3 months post-transplant before they start to get any complications. We know a lot of the patients post-transplant will get complications around about 10 months. So to see them beforehand, it sets that seed that there's somebody that's willing to go and speak to them, and there's somewhere that they can go if they do start to develop any problems. And basically, it's just I'll go in to see patients at 3 months, and they'll be like, no, Angela, absolutely fine. I've got no problems whatsoever. But at 3 months post-transplant, they have other priorities as well. They have priorities of surviving the transplant, getting through everything. So it's actually a matter of having that seed set that there's somebody that will be willing to talk to them about it, and having a bit of a toolkit of where to go to if there are issues.
Yeah, you've already kind of validated that might be a recognised problem by starting to have that conversation really early. And yeah, I think that's an incredibly valuable, and I would agree that that's a great time point to start flagging those issues up, issues of sex and intimacy with our patients as they're starting to emerge from the depths of their transplant treatment and starting to emerge into a sort of more of a recovery phase, hopefully, for many of those patients.
Sorry, Michelle. I think also, at that point, I think it's also given the patients permission that it's actually okay to have sex, because they're also thinking, perhaps I shouldn't because of perhaps infection, perhaps of bleeding, and all of these other complications that, we go on so much about. Please be careful, making sure you don't sort of like go in crowds and things, and, all the things that we actually impart upon them that is a concern. Intimacy and sex is important for these patients. So it's actually giving them the permission to think, yeah, you can do it if you feel. Often there's other issues that might come up, that fatigue or, those type of things. But I think it's just giving that patient permission.
Yeah, and I think that there's perhaps another bias that we sometimes have as health professionals that influences these conversations, and that's around the patient's age, and around whether they're in a relationship or not, whether they have a partner, and again, Angie, just give us a few sort of insights around that.
Yeah, so I think, it's really important because some of our patients are still not in relationships. We obviously treat from 16 upwards. And I had a really important, perhaps a pivotal moment in my journey within sort of like the women's clinic, when a young girl came to me and was, talking. She wasn't in a relationship, but she was talking about sort of like the use of vibrators and things like that. And, at first you don't know what the patient's going to come and bring, but actually those are the questions that are really important to that patient. And equally, it's important to, different situations are important to other individuals. So I think it's really for us to be mindful that, patients may be in a same-sex relationship. It may be the fact that they are, they're still not sexually active, or they've actually, the relationship might have broken down. And we also know that because of, unfortunately, cancer treatments, that relationships do break down. So they may well be thinking then about getting on the dating scene again further down the line into the mid-age, really. And those things are actually quite frightening for our patients when they're already going through something, such as cancer.
Yeah, and sex and intimacy don't stop being important for people after they hit age milestones either. So, people in their 60s, 70s and even older will often welcome a conversation around sex.
Yeah, and I think sometimes as well, sorry, Michelle, I think sometimes as well with, post-transplant intimacy and actually having that closeness of their individual, relationships is actually more important than perhaps it is for the normal, normal cohort of people. Just because actually you need sometimes that closeness to actually say, I'm here for you. And relationships and partners sometimes feel that, yes, they want to be there and they want to be doing everything for them. And that doesn't necessarily come down to the sexual intercourse. It's actually just being there and being able to support them intimately or, just from a distance.
Yeah. And I'm mindful and appreciate that with our allogeneic recipients we have issues with graft versus host disease, which are a really common contributor to functional problems that our patients experience. But what sort of space do we create for our autologous patients and our CAR T patients? How do we approach those conversations with those patients who might be having a slightly different follow-up plan in place?
And I think that's exactly that follow-up plan that's in place is a little bit more difficult, isn't it? Because they'll go from a transplant centre or a CAR T centre out to their normal general hospitals, and they'll be having, the CNSs that hopefully, or, the nurses that are listening to this podcast now and thinking actually they may be the ones that are following up, because at 3 months when they're discharged from us, it may be that they don't have any problems. So it's actually about, giving the nurses in other hospitals and giving nurses the permission that they can talk about it and the toolkit of knowing what to say and where to go to and signposting them to the right direction. There are a few patients that I've seen in my women's clinic that are, a couple of years down the line that have then suffered for a long time with perhaps menopausal symptoms. It may be dryness, because obviously the graft versus host disease isn't a factor in those patients, but they've still got complications of the treatment, and antidepressants we know can reduce, vaginal lubrication. So therefore those are issues as well that can be, that can occur.
Thanks, Angie. Question for you, so slightly different type. We've talked a little bit about sex and intimacy. Can you tell us the differences between sex and intimacy for those who are not familiar?
So I think intimacy is really, you can be intimate with a patient without actually, with a person, patient, not patient, yeah, with a person without actually having, sex. So a couple can be intimate by holding hands, by kissing, by cuddling, by sharing a bed. And those are intimate acts that we all do. Whereas sex usually is sort of like looking at more of the physical act of intercourse, And you don't necessarily always have to have the physical act of intercourse or penetration. You can still have intimacy and sex to some extent with touching, and whether that's sort of like intimate touching, gentle touching, or whether it's just through sort of like cuddling and just being close to people, really. And communication is a massive factor in all of this. You need to be able to communicate with your partner to be able to be intimate, I guess.
Yeah. And these patients of ours, they have become used in many settings to being alone and isolated from that intimate space. So that can also be quite a jump, from that to becoming intimate again.
That's a really important point as well, because of the fact that patients are probably a few months from being intimate with their partner, because they've either been through treatment for a couple of months on the ward, and then they've got a few months where they've had the recovery phase. Getting back to that intimate situation is really, really challenging. And what I would usually suggest to the patients, because it comes to the point that it doesn't necessarily break down communication, but it's sometimes harder to actually get back on that wheel, if you like. So it's actually about, perhaps redating again, going on a date and making time for them, and then sort of like seeing where it goes, touching, kissing, cuddling, but not necessarily to the intimate level, to the sexual intercourse level, because actually that can be sometimes off-putting. And we know that a lot of the women in particular can sort of like clam up, and they get sort of like what we call vaginismus, where they can't get the penis can't enter into the vagina, because the female just absolutely clams up. And that's really comes back down to confidence and making sure that they feel comfortable with the situation that they're in.
Yeah. And I guess there's also that sense, isn't there, where people look in the mirror and they don't look like themselves. So body image is another factor. So how, Angie, do you think we can help nurses, or you can help nurses today in this podcast, avoid feeling uncomfortable or awkward when they're having conversations with their patients, male or female, about sex and intimacy?
I think it's actually about being open, and it's about being the person that you are, gauging your recipient or gauging the patient and possibly the relative. And John has said, from the studies that have been done, it is a little bit more difficult when you've got the couple in the room, because it feels like there's either a barrier into having that disclosure of what they want to chat about. And when I see some of my women in clinic, they'll be like, oh, I'm pleased I didn't bring my other half and things, because I'm not sure that I'd have been able to tell you that, but because they can be very, very honest. So sometimes getting the patient alone to be able to disclose and to perhaps open up. And I think once they feel safe with you and feel that they trust you, it gives that sort of like confidence for them to share some of that information. But I think from a nurse's perspective, it's not easy. I'm not going to lie. It comes with confidence. It comes with the experience of actually just knowing what to say, where to signpost to. And sometimes you can open up a can of worms and you're thinking, oh, where's this going? What do I say here? But actually, we've all got experience of it to some level. And it's actually just being that honest and, engaging what the patient wants, really.
Yeah. The patient isn't looking for a sex expert when they need to talk about this. They're looking for somebody that can validate and acknowledge and signpost or refer on. Thank you so much, Angie.
And I think that, Michelle, comes back to, in my opinion, good nursing care. At the end of the day, most of us get into this profession because we're, I hope, kind and caring. And that's what we want to do, is be kind and care for our patient group in whichever patient group that is, pre-transplant, post-transplant, not even transplant, something else. That's what we're all about, is looking after our patients. And if in any way you can help somebody with whatever burden it is they've got, and if they're worried about sex and they've never spoken to anybody about it, and you have now discussed it with them, then you have in some way eased a burden for them and you've helped them out. And I think that's really important for nurses, no matter what that question is, whether it be about finances or if they're a kid that's going back to school and they're worried about university course. I think as nurses, having that empathetic touch and being kind and caring and knowing your patient. And I think when transplant patients are in, as nurses, we look after them for days and weeks and months, and you really get to know the patient and their family so well that at some point, hopefully the penny drops with you as the nurse, that you think, I can now ask them a question which 2 weeks ago I would never have dreamed of asking them, but now I've formed a relationship with them and I can ask them this because I'm comfortable to do it, and I know that I'm not going to upset them or worry them or stress them out. And all I'm bringing in is my own personal baggage, where I might be a little bit worried about it, but I've got to put that aside because I'm thinking of my patient and how worried and frightened and scared they might be in this situation, and I'm trying to help them out. So I think that that's, again, it's nursing care and having really good, solid nursing care looking after our patients.
But I think also as well, you know, just thinking on the nursing care side of things, and I know that this podcast is aimed for nurses, but there may well be some patients that are also listening to it. You know, the topic actually may well bring patients to it, which would be great. And I think if patients are listening to us, is just go and speak to your nurse specialists. If you don't feel comfortable speaking to the doctor, which is often the case, and actually your doctor may well just sort of like signpost you on, but most centres will have a nurse specialist that will be able to speak or direct you in the right direction to get help or get support, or it might even be medication that's needed. So I think it's just about communication between all of us.
Mm.
Yeah, it's part of teamwork, I guess, isn't it?
Yeah, absolutely.
I think we're going to move on. Thanks for coming back in, John. I think we're going to move on to our round of quick fire questions.
Is this like mastermind now?
This might be where we give you points, guys, depending on your answers. But we will give you a restriction if it's about a 2-line answer for these questions. So the pressure is on.
Pressure is on.
Angie.
Yeah. It's a competition.
It's a competition.
It's a competition to see who can stick to the 2 lines. So shall I start with the first one, Emma?
Absolutely, go for it, Michelle.
Excellent. Okay, so we will have John answering first, as we interview John first, and then Angie, unless Angie comes in more quickly. What is the one piece of advice you would give to patients about sex or intimacy?
Oh, that's a horrible question.
You're welcome.
Communication.
That was a line. That was a line.
That was a line. That was a line. Angie, what's the one piece of advice you would give to patients about sex or intimacy?
Well, I would say communication, be open and honest, and just, you know, there's always somebody to go to.
Oh, that was a line. That was a line. That was my line, but longer.
Can you tell these guys work together, guys, on the podcast, if you're listening in? If you couldn't tell, John and Angie do work together, and Michelle and I are looking at them on screen together, chatting away and having a great laugh. So I'm going to ask you a question. It's a quick fire, and we'll just do John and Angie again in that order, if that's all right. And it's a little tweak on the first question. Michelle asked you, what's one piece of advice you would give to nurses in terms of sex or intimacy when discussing with patients?
I would encourage you as a nurse to talk about it. It will open doors that you really didn't think it would, and I would do it.
Great. Angie?
I would say have a toolkit, have a little bit of someone that you know that you can go to. So if you don't know all the answers, just have somebody in mind that you can go to say, right, what am I doing here?
Teamwork makes the dream work. And Michelle, I'm going to let you ask my favorite question out of the quick fire round questions. I love this question.
Right. And I loved actually with that last question that we had something quite different from both of you, which was really nice. Very, very complimentary. You both are. So finally, what is one assumption about sex or intimacy that you would want to challenge?
that you can't have sex because you've had a transplant, because you get an infection and you will bleed, which is fallacy.
Angie?
My assumption that I would like to sort of like impart is the patients think they're the only person that's suffering from this. I can absolutely assure you that there is an awful lot of patients out there that will be struggling in some form with sex and intimacy.
Fabulous. Not fabulous for the patients, but fabulous answers. Thank you. I'm going to, just before we close off the podcast, I'm going to throw it out to Michelle. Michelle, what's an assumption that you would challenge, do you think?
So that for people of all ages, and whether you're in a relationship or not, sex and intimacy, feeling close, are important. And I think we use that prejudgment sometimes it's as a disadvantage for our patients. So open up conversations about sex with all of your patients, regardless of their age or their social situation.
Absolutely.
Definitely.
I think there's no restrictions in age or anything else. My personal one, just because I'm going to throw it out there, is that we shouldn't make any assumptions that our own personal sexual relationships mirror what our patients might be doing. You might find that you learn a hell of a lot of new things from talking to your patients. Absolutely. And there is nothing wrong with that.
No, absolutely agree.
Fantastic. Guys, it's been an absolute pleasure having you on the podcast today. I'm really thankful that you came and you joined us. I normally do a little bit of a sort of summary of the podcast at this stage. We've talked about such a lot, but there's such a lot that we could have spoken about and that we don't really have the time for at this point. But certainly I love that we've talked about challenging assumptions, that we've talked about a shocking piece of shocking revelation from John, that actually there wasn't as many studies out there from the perspective of a male post transplant in terms of sex and intimacy, that there are people out there that we can go to and ask the questions of, and that we are empowered to be the nurses that ask those questions, that we can absolutely bring that topic up with the patient, even if they say, do you know what, not today, thank you, it's not something I'm concerned about, but we can absolutely let them know that we are not closed off to these conversations happening. So we don't have a topic to let you guys know about for the next podcast. We do have a topic in mind, but we're not letting people know on the podcast just yet. But we will let you know through the social medias. I would like to thank John and Angie for joining us today. Thank you so much for your input. It's been a fantastic conversation.
Thank you.
Thank you for inviting us.
No problem. I would like to thank Michelle for co-hosting with me again. We are such a great little team. I love it.
Thanks so much, Emma. And again, huge thanks, Angie and John and Angie. Absolutely brilliant. I really grateful to you both for sharing your experiences, your expertise, and this has made, I hope, for a great podcast, but I think maybe the first of a number of podcasts that we will do on this really important but not particularly well covered topic for our patients.
And on that note, guys, if you're listening to the podcast and you think that there's something you'd like for us to ask John and Angie, if you'd like us to bring them back, please do let us know in the socials via the EBMT website. You can email us, you can pop it into the Twitter accounts if you've got those and you're following us. If you're not following us already, please do follow us on Twitter. There's a Twitter group, there's a Twitter profile for EBMT nurses. That's probably your best one to go to for the start, and then you can go off and find all of us if you'd like to follow us. I would like to thank the background team as ever for taking away this podcast conversation and making it into the shiny podcast that you will all be listening to right now. And as always, I would like to thank everybody that listened to the podcast and anybody that is sharing it with their colleagues and asking them to listen to our podcast and join us. Please continue to do so. We really appreciate your support. If you do have any ideas for a future podcast that you would like us to look at, again, contact us via the email address, via the EBMT website, or just give us a little comment on the socials and we will see what we can do about that. Thank you very much, guys, and have a wonderful day.
Thank you.
Thank you.